were from patients who is very old and they have very thin wall. Outcome, generally guideline do find, as I mentioned, this sphincterotomy can be treated and neuroperforation usually requires surgery. This is the paper from Tom Howard in 1999, but what we have this day. As I mentioned, decompressive stem. This is a treatment for, sphincterotomy-related perforation. So we can treat it, and I think we have the good data to show you that by, the conservative therapy without surgery, outcome is the same in terms of the healing, but the length of stay was much shorter in the one who did not need to go to surgery in our, almost 1,500 cases of ESP over 3 or 4 years. But I show you the new one. If you have perforation right away during perforation, one thing we might consider is to put the fully covered stent again. So not only for bleeding, but this can be used. But bottom line, you have to have the access to the bladder. So you have failed cannulation, you do pre-cutting, and you create a hole. This cannot be worked. So you have to be able to access the bladder, and then you can use this, and they are more serious than that. I'll show you another trick. This is the scope induced because by moving the scope to get the stone out, the posterior wall of the duodenum got a hole from the scope because we cannot see that. The new clip we call Ovesco, the big is just like a big bite. The assembled system is more like a banding. Actually, again, 2 months ago I did one here with banding to do suction and get the whole circumferential of the lumen inside the cap, and then you deploy the stent, and immediately this is sealed. And again, we have done a few, and we even this day we're not scared. We continue our ESP until finish in one go. So once the ESP patient require closing the hole, taking out the stone or a tumor, you require to do stenting, and then patient went home within a few days. So the new management for perforation, I would say that there are 3 types: guidewire conservative stenting, sphincterotomy. Either you do diversion, the compression response is okay. If not, you can think about stenting again. But if not working, surgery will be the last line. But the type 3, 5 years ago, it is algorithm. I used to say that all of them have to go surgery, but now I put Ovesco, the clip, as the next option. Talk about cholangitis, the risk of patient with PSC, hilar block, failed drainage, and recommendation that don't do injection when you don't get in. You have to go in and do retrograde injection. Require PTBD backup. In our consensus published a few years ago, we said that in the advanced bismuth level, always have the PTBD backup because there was a chance of 30 to 50% of post-ESP pancreatitis, and not only antibiotics is enough, you need drainage. And the thing that's the infection or fever don't develop until next 48 hours. So wait, don't early discharge the patient. Keep an eye on those and keep them for 2 days. That's my recommendation. And in our opinion, about the literature, we probably, even in my unit, we no longer put plastic stent in hilar obstruction, always with metallic stent. If you require surgery, maybe pancreas drainage and then surgery, we don't touch the patient for those resectable ones. But for those probably unresectable, we will come for endoscopic metallic stenting. So last topic, I think Professor Jim already mentioned, stent migration, I will upward or downward tissue ingrowth, and talk about the barrier in terms of if we got benign hilar obstruction, what should we do? This is the interesting paper that you can use plastic stent inserted contralaterally to the bile duct, and the main duct, you still keep it with the fully covered stent, and then this can prevent the subsegmental close down and the local or regional cholangitis, and they do fine. We have done a few, and we probably publish this one soon. We got about a dozen of patients by now, and we found that it's good. Only problem we found that there's some migration, and we show you how to compete with migration. Jung Moon from Korea, demonstrate this technique. We use the double pigtail, 5 friends, 7 friends, 10 friends, as the keychain to lock the stent. One is up, and one is down, and you do the locking things. In his paper, he can drop the number of migration from 40% to only 10%. And we have tried the same thing. I hope this video works. Okay, but unfortunately, when we try to push up the plastic stent, the stent migrated up completely because of the pushing forward effort from the, the stent. So we end up with grafting the stent and keep it down. But to make sure that this time when we put the stent inside, it will not push it up again. So we create a hole by using the Alcon plasma to trim the side hole, the inside the duodenum. By using about 60 to 80 watt of cutting pressure from APC, you create a hole and you just go from the side. So this one is currently that you will not push the whole stent upward. And in this one, even we push a big stent, 10 French double pigtail is still able to go upward and hold this metric stent quite nicely without create proximal migration. Okay, in patient with surgical autoanatomy, 54 years old, show you an example of a patient with cancer of the head pancreas, has already done before she got a stone. So we did ERCP and removed stone, and suddenly as soon as we removed the stone, we saw this thing under fluoroscopic view. What do you think? Look like they air filled the bile completely. Actually, this is massive air embolism. At that time, we did not use CO2 insufflation, which is only room air. So this patient, unfortunately, she died, and we thought that this is, replica portal vein and IVC. So this day, we no longer using the CO2, room air. We use only CO2, and actually we got 2 more patients like this, but I think we able to save them by having the CO2, resection detector during anesthesiology, and then also one patient we lift the feet 2 feet up for almost 1 hour. Patient survived, but complained a lot of cramping at both feet at the end. So I think this is the end of my talk. I have no summary because this is just my experience, and you can use your own way of doing. So have a good day in ERCP. Keep calm and good luck. Thank you for your attention.
Thank you, Professor Jan Ransom, for your very excellent presentation, how to tackle the complication of ERCP. Because of limited time, we'll skip the question and answer session. To summarize today morning GI session, we did successfully with 4 international speakers: Professor Usain Tut from Australia, Professor Johan Bon from Singapore, Professor Kim from Korea, and Professor Ransom from Thailand to enlighten the Arctic gastroenterology knowledge. And thank you for the attendance, for your active participation, and thank you for my co-chair, Professor Ushin Mien Sajin. So we will hand over the session to the Master of Ceremony.
Thank you all very much for a very informative talk. Again, I would kindly like to remind the speakers to be on time. Thank you. On a heavier note, lunch will be distributed to your seats very soon. Up next is the Lunch Symposium on Chronic Hepatitis B and C. May I invite the moderators for this symposium, Professor Dr. Daniel Dumont and Professor Dr. Kim Wei on stage.
Thank you for coming. This symposium is dedicated to B virus and C virus. Both viruses are very strong enemy of the liver, and outside the liver we see this afternoon. And the difference is B, we have vaccine, C no vaccine. B treatment but no cure. C treatment and cure, and the op. I think in some years, if B recent C with a definite cure of B is a challenge, but I think it's realistic. You are my friend, my brother. You can present the chef.
Thank you, my co-chair, my teacher, Daniel Dumont. This dance symposium, there are 2 speakers, very famous speakers. One, Professor Tira, on the chronic hepatitis, treatment of chronic hepatitis B, and Professor Dawisak on the treatment of chronic hepatitis C. The first speaker is Professor Tira Piravisu, Professor is the Senior Director of Liver and Digestive Institute, Samitaway Sungapi Hospital. Vice Dean for the International Affairs, Faculty of Medicine, Prince Songla University. Director of NKC Institute Gastroenterology Hepatology. Council member, Steering Committee of Upper South 2000, since 2010 to the current. Professor Tira is well known not only in this region but worldwide. He's an international figure, and Professor Tira will tell us about the current management of chronic hepatitis B. Professor Tira, please.
Thank you, Professor Kim, for your kind introductions. Thank you, Professor Win, and also the organizing committee for your kind invitation. It's my great pleasure to participate in this. I think it's the first time of International GI and Liver meeting in Myanmar. I can see that it's growing over time, so I think I'm glad to be a part of this meeting. My talk today is going to talk about current management of chronic hepatitis B, and it's quite easy. I just end up with this one because as we know that currently there are two treatment strategies for treating patients suffering from chronic hepatitis B. One is a pegylated interferon, which is a immunomodulating agent. You can see that it's a finite duration of treatment, and you know currently we recommend 48-week treatment duration. This one usually achieves higher serological response than antiviral therapy, particularly in the term of S-antigen seroclearance. It's more durable after the treatments, and another good thing is it has delayed response. I think I published 5 years ago that both conventional interferon and pegylated interferon, you can have another 14% delay response after 6 to 12 months after the end of therapy. However, it's achieved seroconversion in about 30 to 40% at 6 months post-therapy. And it requires subcutaneous injections, and if you explain interferon, you can see that it contains a lot of side effects. Even we talk about side effects, however, 86% of the patient able to tolerate to this side effect and able to complete the treatment duration. And another thing is it's contraindicated in advanced liver disease and some with severe autoimmune mediated disease. The other treatment strategy is a nucleoside or nucleotide analog. This is antiviral replication. Currently, we have some agents with very potent antiviral activity, very minimal side effect. Even we have experience over 8 to 10 years with some particular agents. It requires mainly only once daily dosing and can be used in patients with advanced liver disease or even those with autoimmune mediated disease. However, it's always required long term. Long term, I can say that it can be more than 5 years, 10 years, or potentially lifelong in some particular group of patients. Longer duration, it might associate with the drug resistance, and this become less concern because now we have more potent and high genetic barrier agents such as ticagrelor and tenofovir. However, the most important issue clearly is a high relapse after the treatment discontinuation. So if my talk comes to only current treatment strategy for Hep B, I can finish my talk here. So what I'm going to do now, I will go to the both treatment strategy. Even some people not prefer interferon, some people prefer nucleoside, but I will be set in both treatment strategy. How can we optimize the treatment outcome? I will start with the PEG interferon therapy first. Can we maximize the treatment response? When we just mentioned, usually it's about 1/3 of the patient achieve certain response in antigen positive chronic hepatitis B. What we can do is you select the right patient. Look at the baseline patient character. You can see that if the patient has a high ALT at baseline, at least about 5 times upper limit normal, and has a low DNA, less than 10 logs copies per mil. You can see that with 1 year PEG interferon therapy, 52% of the patient achieve certain E-antigen seroconversion within 6 months post-therapy. The other marker now we know, understand about S antigen quantification. This also look at our previous study in phase 2 trial with the Patrick Masson as well. We look at the baseline characteristic and look at the surface antigen level. You can see that S antigen level is less than or equal to 20,000 IU per ml in both E positive and E negative. It associated with the same response defined as DNA below 2,000 IU per ml plus E antigen loss 6 months per therapy in E antigen positive patient, and also DNA below 2,000 IU per ml plus less than within 6 months post therapy in E antigen negative patients. So this is another baseline characteristic. And recent baseline characteristic with published from China, from Jilinghuo group. They look at the anti-HB core level at the baseline. You can see that higher anti-core level at the baseline associated with a higher certain response, including E antigen seroconversions up to almost 53%. And also DNA, mind you, this very stringent criteria, look DNA less than 200 IU per ml, see in almost 50% of the patient, and also E loss plus DNA below 2,000 IU per ml seen in 42% in those who have a high anti-HB core level at the baseline, higher than 50,000 IU per ml. So that just to simplify what we can do at the baseline before you starting prednisone. You can look at the clinical response. This we did with the Henry Chang and presented at the EASL meeting 2 years ago. Look at the baseline of E antigen positive chronic hepatitis B, such as gender, DNA genotype, ALT at baseline, antigen quantification at baseline, and DNA level. For example, if we have female patients, ALT at least 4 times according to normal, have surface antigen level lower than 20,000, and DNA is just about